us for our Patients Losing Patients Forum. I'd like to welcome you this afternoon. We had a great team of people who put together this forum for you, and we hope that it will be informative and a good experience. Your moderator today, as well as your MC, is William F. Raw.
Thank you, Monica. So today we come to you collectively, hoping to convey and educate and advocate for patients who are losing patients. And one of the goals of today, as I said in the previous sentence, is definitely to educate. And it's not under the assumption that you all are not mindful of the importance of healthcare and the importance of being sure that gaps in healthcare are filled. But it is also to remind you that we're not in a packed room and there's not thousands of people and there's not lines outside and the media is not up there and the balcony's not full. That, in essence, to me, illustrates the importance of having a forum such as this. Because what we do know is a lot of these issues arise and continue to arise because it is not provocative or sexy to stand up for things that don't appear every day on the cover of our newspapers and on CNN or MSNBC. That is exactly why forums like this are important. So I want you all, before we even begin, to look around the room and acknowledge those people that have taken time out today on a football day, on a Sunday, when school's starting, because these are the people that are here that are dedicating themselves to not only this cause, but a lot of other causes. So I also want to applaud you. So. One of the conversations that we had right before we began in reference to today's proceedings were why you have something like this. So your mission and your super objectives. There's various levels of objectives. The super objective, of course, is to highlight the fact that there are patients that are not being adequately considered when political decisions are being made in reference to health care. So keep that in mind as kind of a subconscious backdrop as we move forward throughout today's PowerPoint presentation, as well as all the amazing speakers that are here. So I want to jump right into it. I also want to apologize to you all that we did not begin exactly at 5. And the reason why we did that is because we want to ensure that as many bodies are here and as many people are able to hear what our amazing speakers are going to be talking about today. So bear with us as we move through this. I'd like to also begin by personally and hopefully collectively thanking all of those people who have put in a lot of time and energy that I want to repeat are not being paid and are not sponsored by pharmaceuticals. So there's no pharmaceutical reps who give us fancy office space and provide people supplemental salary. These are all parents and members of your community who have taken a lot of time and energy to present something like this. So Monica LIndsey. Phil Atedo. Robert Smith. Chrissy Holt, Art Holt, Melissa Hagan, Yasmin Jameson, Sonia Feldman, Eve Hurwitz, Tracy Havermel, and Ted Weber. And there's another person that I want to thank, both for hosting some of the preliminary meetings, but also just tireless work behind, and a lot of this is responsible for this person, Eric Graber. And that's Eric at the table there. Okay? All right. So there are people that are not on that list, and that does not mean that they are not equally as important. And if there was an oversight in terms of your name being on that list, please don't take it personally. So we're all here collectively together. So let's begin. I will be your moderator, which means in between the presentations and in between the PowerPoint sections, I will come up and introduce the speakers that will be coming up. Right now, I also want to acknowledge and recognize the Bates Legacy Center and the wonderful space that's been provided, but also a community space. You all don't know about the legacy of Bates. It was a school at one point in time during segregation where the African American students in the city of Minneapolis and surrounding areas attended this school. And it was a space that has a lot of history personally for me, as my grandmother went here, and a lot of other family members. So thank you for this space, Bates Legacy Center. And we're also, what we also like to do in using spaces like this is to support them financially. So the minimum we request each of you, I don't know if they told you this when you came in, but each of you have to make a $200 donation, like right now. And we have PayPal already set up, so no, honestly, they are accepting donations, and any amount will do, from a quarter up to, like I said, $200,000. So our first speaker scheduled today is Ben Jealous. And Ben Jealous is not quite here yet because we are in Maryland in the DMV area, so it could be traffic, could be prior engagements. It's also election time, so people are making their rounds. So we'll move forward with the agenda, and when Ben arrives, we'll jump right into it. If you all don't know, Ben is running for governor. He was previously the president of the NAACP. And also an advocate. So we want to move into our presentation beginning with Robert Eon Smith. And what Robert brings to the table is not only is he a volunteer, he's also an advocate, as well as he has worked tremendously on parsing out the history of healthcare, so giving a background on healthcare. And what Robert is going to be doing today is talking about how healthcare is essentially a human right. So I want to introduce to you Robert Eon Smith.
The reason why we wanted to do this today is I know when I first started advocating for for healthcare through the years, I thought a lot of the stuff that we were asking was unique and very distinct for the time. And then a lot of times when we go in the doors of politicians, you know, they'd be treating us like what we were asking for was something radical. And then as through my years of doing this, I had learned a lot about the background and the history, and learned that a lot of what we're asking for is nothing new, and it actually goes back for over 100 years. So real quick too, there's going to be a lot of information on these slides, so we'll be providing these on through our website afterwards. So there's a lot that I'm just going to briefly touch on, or may have to skip over just for the sake of time. So so a lot of this, I'm hoping that one of our goals of this forum is to educate, so that people would seek out the slides and seek out the information on them. I have this quote from President Harry S. Truman, just again to show that this is not a new struggle that we've been fighting for. So This quote is basically, "None of this is really new. The American people are the most insurance-minded people in the world. They will not be frightened off from health insurance because some people have misnamed it socialized medicine," which I'm putting it up there obviously for the irony's sake, because through many of the years, this has been exactly the thing that has prevented us from moving forward on this. So this is a basic timeline of the different kind of key moments or key legislation that's happened on healthcare through the years, and we'll be so first spirit we have is the first piece of legislation is the American Association for Labor Legislation. This was around 1914, 1919 after the First World War. So this kind of sums it up, where the idea of providing insurance against the risk of medical expenses was largely unknown at the time. So, America was just kind of, we were in the midst of still going through the Industrial Revolution. We were fighting a lot for workers' rights. So the idea of having a public insurance and having a thing that would help, for the common welfare of all, and like protect the needs of the workers was coming out. Basically, no government program had existed at this time, and commercial insurance companies had yet to venture into the business of insurance. It was considered an uninsurable moral hazard at the time. So a lot of this was like with industry, and at the time, a lot of sick people, and how to, like solutions on how to prevent that. So basically, basically it was a result of this. It was a lot of academics and middle-class reformers who came together and kind of wanted to do this through a scientific methods. And then basically all this was kind of done of like smart people in a closed room. And that's where the focus I want to stress with this history is that a lot of the real reforms that we've had through the years has really come from grassroots efforts. So basically, ultimately, they moved through, they got introduced in 14 state legislatures in 1917, but it was only considered in New York and California. And both of those states, it was defeated due to oppositions from physicians, businesses, insurance companies, and conservative legislatures that were united in declaring the health insurance was, they're saying it Bolshevism, but it was also more of a jingoism and fear of like with foreign governments and foreign governments having influence. They promoted their work, again, this is a stress, that they promoted their work through research, lobbying, and expertise. As a result, though, of this effort, we did get the first time that insurance companies began to offer health insurance products. Metropolitan sold its first individual health policy in 1921, and Prudential began selling group health insurance in 1925. So this period is the 1934-1935, so this is during the Great Depression. Basically, this sums up a lot of the social safety net that Franklin Delano Roosevelt had put in. As a part of that, there was a national health program that they were exploring. And that was put forward. And this is going to be key for the next slide, because Harry Truman, as his vice president, was involved with this and was very much in favor of a national health insurance thing. But in this period, when the Social Security bill had gone through, they had dropped the national health insurance as in order to get the other provision passed. But again, this was people behind closed doors, government politicians making decisions, and not people coming out and doing the grassroots effort. So this gives us the 1943, the Committee on Wartime Health and Education. Again, this is Roosevelt's, then eventually Truman, and again to push for a national health program. As a result of this committee that they had, the national health insurance gained attention in the media, including a poll that found that at this time, 82% of the public agreed that something should be done to help people pay for medical care. So again, we're not unique today. This is something that we've been dealing with, again, for over, in this case, we're over 70 years. So again, this was another bill that was brought right before during the war, and then we were dealing with afterwards, and then Truman got involved with the efforts. In 48, like I said, Truman was very much on to wanting to do a national health insurance policy and doing like a national health program for the U.S. So when he was elected in 1948, the American Medical Association kind of was concerned because they knew this was a big piece of legislation that he wanted to push through. And so they brought they spent over $1 million on anti-health reform public relations media campaign to fight him on that. So this is why I want to bring in President Truman. So he basically wanted a national health program put in place. So this is from he had a. Basically, so what I have here is he outlined the five critical goals of national health. That's to meet in his words, to meet the problems, I recommend that the Congress adopt a comprehensive health reform and modern health program to the nation consisting of 5 major parts, each of which contributes to all the others. So these 5 points were constructions of hospitals and related facilities, an expansion of public health, maternal and child health services, medical education and research, prepayment of medical costs, with him quoting and saying, everyone should have ready access to all necessary medical, hospital, and related services, and protection against loss of wages from sicknesses and disabilities. So he was definitely on board in pushing for a Medicare, and then out of this process, this is where we got Medicare, the idea of Medicare and Medicaid. And he wanted to push it. And so in its original vision, it's not exactly what we call Medicare for All today, but it was a vision that was supposed to include all American citizens. And that was the other point I want to do is, so these were the 5 points he outlaid in 1943. Have we even met these goals today with the policies that we have? So again, this is a 70-year struggle. And then I want to bring up these two folks. These are two very important people that, and I could probably spend hours talking about these two folks. So on the left is a woman named Leon Baxter, and on the right is a person, his name was Clem Whitaker. So what they were is the first political consulting campaign hired in the U.S. And then why they were very critical to this was not only, so California had a Medicare for All proposal that they first tried to push, actually under a conservative governor who actually wanted it because of his own health failings. And then I believe the American Medical Association had paid them to do that, to basically bring out this whole idea of socialized medicine. So the reason I'm bringing this up is, so I don't know if people here are familiar with the term astroturfing. Astroturfing specifically refers to which is things that appear to be a grassroots movement, but in actuality they're paid underneath by like a very wealthy entity to make it seem like a grassroots movement, but it truly isn't. And these were the people that eventually created that. So at the beginning of 1949, Whitaker and Baxter and the directors of AMA's National Education Campaign entered national politics, setting up the headquarters in Chicago with a staff of 37. Their goal was, quote, the immediate objective is the defeat of compulsory health insurance program pending in Congress. 2, and this is key for today, the long-term objective is to put permanent stop to the agitation for socialized medicine in this country by an awakening to the people to the danger of politically controlled government regulated health system and convincing the people through a nationwide campaign education of the superior advantages of private medicine as practiced in America over the state-dominated medical systems in other countries. Campaign Inc., which was their public PR firm, and AMA spent over $5 million at the time to sponsor radio, newspaper ads, direct mail, as well as encouraging people to write their members of Congress. So where you had back when I early, like 82% of the American public who were very much for a national health program, they were able to create an hour of a grassroots thing to turn people against it and then create this myth of socialized, or the thing that we still hear today, which is the socialized medicine. And create this whole idea of the foreigner and all that. It seems that we've never been able, or it's always dogged us in our fight for improved Medicare for all. He basically had sent a pamphlet called the Simplified Blueprint of Campaign Against Compulsory Health Insurance. He distributed this to hundreds of thousands of reporters, editors, and among others to every member of Congress. As a post factivist, also to show that even though that it was the American Medical Association that sponsored this was not very popular with the doctors that participated in the AMA. So that's where I included this quote. Carrick McWilliams had wrote a highly circulated article in The Nation in which he basically said that for the AMA, they had written what he said, a political script in which doctors originally cast as special interest heavies emerged as the crusaders for the people's health. The government, and this is Government by Whitaker and Baxter. And then as a result of that, too, you'll see there's another quote we have here. Is from by 1952, a number of doctors had resigned from the American Medical Association. James H. Means, Jackson Professor of Medicine at Harvard and the Chief of Medicine at Massachusetts General Hospital, explained that he was no longer willing to pay dues that had been used to support an activity that he considered contrary to the public welfare and unworthy of a learned profession. So, in all this, if I encourage, if you, it's a report done by the New Yorker in 2014, and full history about that. So, I encourage people to follow up. So, this is a key photo. So, we get up to 1964-65, the National Council of Senior Citizens, which comes out of that. So the key here, and the reason I want to show this picture is this is Johnson on the left, and this is President Truman here. And the reason that Johnson had brought Truman to the signing of the bill that basically enshrined Medicare and Medicaid was he wanted to make sure that Truman could see that it actually finally got through. So basically, as during this period, American Federation of Labor of Congress, Industrial, and AFL-CIO organized retired union members, and out of this basically process, this is where we got Medicare and Medicaid. But again, at the time, the original intent for Medicare was to have it include everybody, but as a compromise to finally get it through, and then Johnson did this as a part of his war on poverty, he had to do it restricted to just the people aged over 65. So that was just the jump ahead. And I guess just to bring up real quick, because I need to probably shore up for time, there's again another attempt for healthcare reform in the 1970s. It was led by labor organizations and reached out to civil rights and anti-poverty organizations. But again, this was kind of a time, again, where it was a lot of experts meeting in rooms and talking about ideas and what would happen. A lot of it got derailed by a lot of it. As this quote here said, reform lost momentum when the massive healthcare inflation in the 1970s led an emphasis on cost rather than expanding coverage. But as the number of uninsured began to rise in the 1980s, public discontent intensified. So just again, an echo where again this got derailed because it was experts in the room deciding on what was best. At the same time, we were getting the American with Disability Act, which was another grassroots effort. So again, that's the importance of all of you here, is getting you here. That's what we've seen consistently that gets health care on the table and get what we want. So I bring this up today. So this is the Health Security Act of 1993, which was obviously famously spearheaded by the Clintons. This picture we use particularly because Bernie, she famously said in the past election that, Bernie wasn't there, but Bernie was there. But the idea of this is basically what happened is where a lot of our healthcare became even more privatized. If a lot of you are familiar with this time, this is when we got the HMOs, and the HMOs is, we had to go through everything had to go through our primary care doctor for every little thing. If we need to go see a psychiatrist or if we need to go see this expert and all that, it had to go through them, and that became a kind of a mess, and it kind of started ballooning because, again, the emphasis here ended up being on privatization as being the answer. which leads me to this quote. So one physician activist dubbed the plan the Health Insurance Industry Protection Act of 1993, and another agreed that managed competition won't control costs and the entire healthcare system will be owned by a handful of insurance giants, which is what we got today. So, and the nearly 400,000-page proposal was far too complicated and confusing to inspire popular movements on its behalf. Activists concluded that few could or should rally to this banner. So again, a bunch of experts in the room decided what was doing. We don't get what we want. It was what works is grassroots effort. So that brings me to what was shared. Professor David Barton shared in a history of healthcare and from the Oxford Handbook. And so one of the key things he related with that was at the core of what is going on is the conflict is healthcare a public service or a commodity? It can't be both. We got to make that decision. I assume that most of you in the room here would agree that the reason why you're here today is that you agree it's the former, that it's a public service. There's a second point that when healthcare is viewed as a social good, there's social solidarity. That when we start to, his second point was when it's viewed as a commodity, people don't want to pay more from what they need, or they feel, they worry about the cost and they're not worrying about the benefits to us as a whole. The basic requirements his arguments of these 100 years of more palatable approaches, in quotes, is that we have basic requirements are compulsory coverage and effective government oversight. So again, just to phase up what I was saying, these are kind of like a different way he grouped it, which was these are all the different steps that we've tried in the past of group solidarity, volunteerism, collaboration, management, and privatization. We've tried to do healthcare reform, but it hasn't worked. And then basically the only thing that makes sense is we keep coming back to that what every other industrialized country has learned, that the social insurance model is the only feasible path. So, and then that was his final quote, which was the practical mechanics of how to make such a universal healthcare system work are a lot easier than patching together the existing hopelessly fragmented private-public health insurance system. The Medicare program actually does this quite well, and the cry of Medicare for all has never been silenced. Indeed, no one has ever objected to the mandated coverage under Medicare. So that brings me up to the ACA and our next speaker. So thank you.
Provide an introduction for our next section. This is Dr. Eric Nornberg, and he is co-chair of Physicians for a National Health Program, the Maryland chapter. He is also a part of the Leadership Council and also Healthcare as a Human Right for Maryland. He's also on the steering committee of Health Over Profit for Everyone. He works full-time as an advocate for single-payer health reform. And for more than a decade, he has taught pediatrics at the University of Maryland Medical School, from which he retired in 1997. He remains a fellow of the American Academy of Pediatrics and a diplomat of the American Board of Pediatrics. He obtained his medical degree from Mount Sinai Medical School in New York and his master's in public health from Johns Hopkins in Baltimore. Dr. Nornberg has devoted considerable time and energy to advancing both national and state-based single-payer legislation. He's also edited a major single-payer fiscal study entitled Financing the Maryland Health Security Act by Gerald Friedman, PhD, and served as Healthcare Now's legislative coordinator in Maryland. He currently serves both on the Leadership and Administrative Council of Healthcare as a Human Right here in Maryland. So I bring to you Dr. Eric Nornberg. Thank you.
Boy, that guy sounds really good to me. I don't know. Well, my name's Eric Nornberg. I'm here to talk a little bit about our campaign, Healthcare as a Human Right. started it in 2012 as a sort of to follow on what Rob was saying. We had worked as a group of experts and citizen lobbyists for a single-payer bill in Annapolis and realized that we weren't getting anywhere. We were getting the same results every year. And what we really needed was the grassroots. And so that's when we shifted. Raised a bunch of money to have a fancy study. And we said, well, maybe there's a better way to spend this money than to, have a fancy economic impact study. And that's when we started looking for a full-time community organizer. We have one now. Her name is Brittany Shanahan. Before that, was somebody who many of you may know, you may remember Sergio Espana, who was terrific. So it was put together by three groups really, but two groups primarily. Healthcare Now of Maryland, which is a citizens activist group that's been around for a long time. They're still active as part of the movement in Baltimore. And they got involved when there was discussion about privatizing Care First. And then Physicians for National Health Program, those are the experts inside the room. They are founded by two Harvard professors. It's a group of 21,000, mostly doctors, and they put out a lot of good research. Everything we do, we try and be scientific about what we're supporting. We try and have evidence to back up. Contrary to what we've been hearing from some politicians recently, we really have thought about this stuff, and there really is a lot of plans on the table for how to get it done. And as one of my friends says, there are a lot of models out there in the world to look at, and there are, because we are a singularity here in Maryland. We're the only ones who rely primarily on a private model to deliver private public model to deliver health care. So here are the human rights principles. Universal means everybody in, nobody out. Equitable means equitable access. That means no barriers to access at the site of care, at the site of delivery. Everything is paid for in advance. So there's no co-pays, there's no deductibles, there's no thinking about, is this serious enough to go to the doctor or not? Because we know that even doctors aren't so great at always knowing when they should see a doctor, but people often make the wrong decision about going to see the doctor when there's money involved because they think first about saving money. Take that out of the equation, then people will go when they need to go. Equitable in financing, which means that there will be some kind of financing mechanism that is progressive, so wealthy people pay more, poor people pay less, I think, or subsidized. And accountable, transparent, participatory, those are just that it's going to be something that it's going to be a simple system, so it'll be something that the public will be able to follow. Healthcare is extremely complicated, and we've made it so much more complicated by all these insurance plans and groups. So single payer is one system. Everybody's paying pretty much the same rates. The doctors have billing. You have one card that you get the day you're born. Your mother got the same card before you were born, and it's good until the day you die. Do it as a public good. What America has gotten into is the trap of talking about, we don't talk about healthcare anymore, we talk much more about commodities, business language, the language of business. We talk an awful lot about health insurance, which we know health insurance doesn't always mean health care. And we worry about saving money, a lot of times means we're preventing people from getting care. What we really want to be talking about is how do we get people care and how do we set up a system that saves money, not how do we have corporations that will save money. What they do with their saved money is they do what corporations are designed to do, which is they put it into extravagant salaries for their executives and they pay back their shareholders. Since the Affordable Care Act has gone into effect, health insurance stocks are up by about a factor of 4. So it's been a very profitable 5 or 6 years for health insurance. So this is a quote that Martin Luther King Jr., he's such a poet. All the forms of inequality, injustice in healthcare is the most shocking and the most humane. He said that in 1966. And it still rings very true. So this is kind of a comparison of single payer on the left and the Affordable Care Act on the right. The Affordable Care Act, sometimes also referred to as Obamacare. Single payer, sometimes referred to as Medicare for all. So it's a universal coverage. Yeah, it's universal coverage. Everybody's covered automatically. The Affordable Care Act, no, we still had close to 30 million people uninsured, and at least that many people who are underinsured. At least that many people are underinsured. So we have about 30 million uninsured, and at least that many who are underinsured, and those are people who have large copays, large deductibles, and have to weigh what's in their pocketbooks before they decide whether they can go to the doctor or not. Cover all medically necessary services, so we're talking about everything. We're talking about dental, we're talking about vision, we're talking about mental health, we're talking about services for addiction, hospitalization, all of that. The Affordable Care Act, no. The insurance companies continue to give us weaker and weaker policies. You don't get full coverage, you get partial coverage. Metal plans, those are explicitly partial coverage. Bronze, you're 60% covered. The silver, 70%, and so on. We know there's tremendous savings in single payer because you wipe out all these administrators that are working for health insurers, they're working for hospitals. You now have more people doing billing in hospitals than you have beds. Just way distorted. I'll show you a slide about that shortly after. We know that the Affordable Care Act has only increased the costs of medical care. It's sustainable. Single payer is sustainable. Unlike what Obama said when you said you can keep your doctor if you like them or your insurance plan if you like them. Well, in single payer, you get your choice of doctor, your choice of hospital. There's no in-network, no out-of-network. Everything is in-network. And another advantage of that is that you're always insured so that you're not stuck in a job strictly for insurance, and there's a lot of people who are doing that. Leave your job and still be insured, and then progressive financing. I'm going to skip over this one. Just the column on the right was the travesty that the Republicans tried to pass, where they were going to take insurance away from 25 million people or 25 million people, depending on which version. The back room at an insurance company. Are you crazy? Government health care would be a bureaucratic nightmare. Well, the bureaucratic nightmare is them. That's who the bureaucratic nightmare is. This slide is a little hard to look at, but the green stuff is the number of new administrators. This slide continues to look like that, only a little worse. The yellow line smudge at the bottom is the number of doctors. So we've just had an explosion of administrators. And they're in 3 places primarily. They're at the insurance companies, they're at the hospitals, and they're also at your doctor's office. And you'll See, you know, when you go to your doctor's office, there's 3, 4, 5, 6, 7 people behind the desk doing stuff, pushing paper, and that's all they're doing is pushing paper. This is just put up here to remind me that we have at least 2 single-payer systems in this country. This is Medicare is one of them, the original Medicare, not the new Medicare. And this is looking at what happens with people who have, I'm not talking about now about the private part of Medicare, I'm talking about people who have the regular part of Medicare where the government is the insurer. And what this is showing is that when people, these are rankings of us compared, the United States compared to 17 other countries, and you can see that for a long time we bump along the ground there we're at 17 or maybe 16, and then something magically happens at age 65 and the curves where our healthcare becomes similar to the outcomes of people in the rest of the world. And what's happened? Everybody who's over 65 is insured. And that's what we're looking for. We're looking to have this curve go all the way back to when you're born. To demonstrate that costs of healthcare, this is insurance costs for people who have preferred provider PPOs. Cost has risen. This line here is the out-of-pocket expenses. Blue is what the employers are paying. Yellow is what comes out of the employees, comes out of employee salaries, and green is what's coming out of your pocket, and that continues to go up. This is just some examples of why people are having trouble. These are the plans inside of the health exchanges. You can see that an average bronze plan has a deductible of $5,700. So if you're not getting any kind of support from the government for your care, you're going to be out at least $5,700 before you start, except for some services now that are covered. But for important services, no. For severe services, no. For some of the preventative services, yes, there is coverage that you don't have to deal with a deductible. This is why we have a crisis. This is why people are feeling the pinch. The top 2 lines are cost of health insurance. What's happened to it over the last almost 20 years. You can see this stops in 2012, but the curve doesn't change much. And then below is what's happened to people's salaries. So we're paying more, people are paying more and more for their health care, but their salaries haven't kept up, so they're falling. I throw this in here because this is HR 676's financial plan. It's also a complicated slide. I tried to get Jerry to change it when he first came up with it, but this is 20, 40, 60, 80. These are what happens to people's incomes at the as they go up the income curve. Somewhere around 200, and with this form of financing, somewhere around $225,000 annual income when you started paying more for last thing I'm going to do is quickly go through. This is just to demonstrate that still lots of poor people are still not doing as well as everybody else in spite of the Affordable Care Act. This is what's happened to uninsurance among children. This is what's happened to uninsurance among everybody else. So the poor and the near poor have 3 times the rate of this slide is totally unreadable. even I can't read it. It's a survey. It was a survey that's done by this group called Merritt and Hawkins. A couple of them here. They went and did secret shopper surveys where they called up doctors to see how long it would take to get an appointment, and basically, depending on the specialty, it could take anywhere from a couple of weeks to sometimes 3 or 4 weeks or months for some of the more severe things, and then also showing that a lot of doctors are not taking Medicaid, which is where most of the people who were helped by the Affordable Care Act gained their coverage. That number has not improved since the Affordable Care Act. In some cases, it's gotten worse. So this is my final 3 slides, I guess. The Affordable Care Act went into full effect in 2014. When Medicare went into effect, you started to see some improvements in health outcomes almost immediately. We have yet to see that. This is life expectancy. What's happened is last year, for the first time since 1993, life expectancy did not go up in the United States. It stayed the same. And it looks, from what I hear, it looks like 2016 is going to be similar. So we're not seeing, what I'm worried has happened here is that we've given money to some folks and let them have more access to care. At the same time, we're pulling it away from other folks and maybe ending up in the same place that we were to begin with. Sorry. Okay, sorry. And then the last slide here is infant mortality, which has also remained the same. A number that's close to my heart because I took care of kids. This is what's happened in Maryland during that time period. You can see that infant mortality had a nice drop from about 2007, 2006 to 2010, and since then it hasn't changed. It also exemplifies some of the discrepancies by race. This number has actually improved some with the black to white death ratio, but it's still obscene. So anyway, I would urge you all, we have chapters in 7 places. Healthcare is a human right, Maryland. One's here, which is Rob, Phil, Ted. We have one in Howard, City, Frederick, Carroll, Burgess County, probably Baltimore City. So look for us on the website. Come to our meetings. They're monthly meetings in most places. This has been a good time for us. We're getting to talk to politicians. We're getting to talk to a lot of people who are activated. The grassroots is starting to come out, and this has been a chance for us to try and educate, like we're doing today, try and educate people about why single payer is the solution to our problem, and not some of these incremental changes.
We also add information for you all as you leave. At the front table, there are items that you can take with you to give you information on who to contact and for advocacy purposes. So please feel free to stop by there and grab some things. So our next speaker is someone who is important to me aggressive approach to a lot of the issues that we're talking about. Importantly so because we are in the state of Maryland, which is vanguard, I believe, in progressive issues, specifically on the East Coast. His name is Benjamin Todd Jealous. He's running for the governor of this great state. And he's also an advocate on a lot of social justice issues, most notably to me also on police accountability. And he was the former chief and I'm sure he has some amazing things to bring to you, so I want to bring up Benjamin Jealous.
Well, it is a joy to be here with you this afternoon. I want to thank my friends at Physicians for National Health Program for laying out the case. The case, I think, unfortunately, is obvious. We need to do what every other Western nation has done to make sure that all of our people have health care. My name is Ben Jealous. I'm the former national president and CEO of the NAACP. I co-chaired Bernie Sanders' campaign here in Maryland. Anne was the first Bernie surrogate to endorse Hillary Clinton because, well, I was on fire about making sure that Donald Trump did not get in the White House. And now that he is, we have to be prepared to make sure that everybody in Maryland has health care no matter what happens in Washington. This is an issue that has impacted us for a long time. Many of us can call the roll on family members, on friends who died untimely deaths. It's President Obama's own mother, because they did not have access to health care. Less visible, but just as present, is the fact that high health care costs are the leading cause of personal bankruptcy in our state. On the campaign trail, let's get rush out again. I've got to get over to the Eastern Shore. I'll tell you that story in a second. So traveling across the state, I've met women 80 years old who have gone back into the workforce, taking care of 96-year-old men because they can't afford their pharmaceutical. The chairman of my campaign works at Horseshoe. State and the Wharton School of Business. Because of the impact of the recession on his business, found himself in a place ailing for his wife where he had to go back into the workforce to help pay for her pharmaceuticals. As Americans, we are 5% of the world's people, and we are 60% of Big Pharma's profits. Healthcare for all, Medicare for all, single payer, whatever you want to call it, is the only way that we get a leg up in negotiations with pharmaceutical companies so we get a fair deal instead of a raw deal. And as you heard, the VA, Medicare, public options, public systems in our country, the overhead's about 3%. Private systems, like what I pay for at work, it's 17% or 18%. 5-6 times higher. There's a lot of savings to be realized. It is a matter of personal tragedy that is moral imperative that sometimes is hard to grasp until you run into somebody who's reeling from the impact of this obscene lottery we call the American healthcare system. Right? It's like musical chairs are the worst kind. The music stops and you don't have a job, you might lose your life. I was talking to a room like this, a little bigger union meeting, and a friend walks up afterwards I didn't expect to see him. He's a white-collar professional. I met him at the Bernie campaign. He's an activist in Montgomery County, just not a member of this union. And he's bawling, and he won't stop. And I give him a hug, and I just say, brother, just take a deep breath. I know what you're saying is important, but I cannot understand you. Just take a deep breath and slow down. And he says, you said up there that when you were young you had a seizure disorder. I said, that's right, I had juvenile epilepsy. It was with me from about 2 to about 24. He said, and you said that there was periods when you were young when you didn't have health care and your family worried that you may not be able to access your medication. You might die. I said, that's right. When I was a young organizer in Mississippi, a doctor at the public health clinic, would literally steal medication to make sure that I wouldn't go into static seizure during the months I didn't have health care. He said, well, my girlfriend died from an epileptic seizure 5 nights ago. He said she was a 52-year-old psychologist, world-renowned in her field, had hit a gap in her health care coverage. We were terrified that the worst could happen. I didn't hear from her for a couple of days, so I went over to her apartment, and I found her dead in her bed. He went on to explain that her father is a doctor in another state who runs a medical center. And when he had to call him to give him the horrible news, the father asked for his daughter's death certificate, and he got it to him. The father's on the phone with him, and he says, well, that's right, that's why my daughter died. It's the technical reason, asphyxiation from an epileptic seizure, but let's be honest, she's no longer with us because she, at this point in her life, did not have health care coverage. That's a month ago in Montgomery County. At the point we're talking about, a woman with multiple degrees in the wealthiest county in our state dying for lack of health care. This is officially no longer about those people or other people or somebody else's problem. This is about all of our families, all of our friendship networks. We have hundreds of thousands of people living in terror in this state right now because they do not have health care coverage. And millions of more people who care about them worried as well. And we could have hundreds of thousands more if Trump care ever gets through. And there's lots of moneyed interest pushing, hoping that eventually it will get through. And so what do we do? Well, I can tell you, as somebody whose first major experiences in our state capital, taking real risk, came in a year when the civil rights community had decided that this would be the year to abolish the death penalty, this would be the year to pass marriage equality, this would be the year to pass the DREAM Act, and the year to pass sensible gun safety reforms. And we were told that that could never happen in the state capital, that any one of those was likely impossible, and if you try to do all of them together, it was certainly impossible. And that year, I co-chaired the effort to pass the DREAM Act. I led the effort to abolish the death penalty, that final push that succeeded. Put organizers on the ground from the NAACP to help pass marriage equality. And we were all in around gun safety reform. And we won every single battle. And we did it the same way that we will win this battle. We built bigger, more robust coalitions than anybody thought was possible. Because we were willing to speak to the pain and the truth behind the righteousness of our cause. We have an opportunity here to do something in Maryland that has not been done in any other state. And the first thing people will say to you is, oh, they tried that in other states and they failed. Well, that's one mindset. I invest in technology for a living. That's what I've done since I left the NAACP. We invest in double bottom line companies. And when you invest in technology, you run right into a different mindset. It's the mindset of Thomas Edison, who invented the light bulb, who failed 1,000 times before he created a light bulb that worked. It's the mindset that says that every time somebody else tries and fails, the odds of us succeeding goes up. Goes up. And so, yes, it is actually because other states have tried and failed that we are more emboldened, because we know we can learn from their experiences. And that makes our plans, our approach, better and more politically viable. It's also the case that in this country, if your state is going to create a healthcare for all system, you must have a federal waiver, and nobody knows how to get that from Donald Trump. Well, guess what? Maryland already has it. We don't have to get it from Donald Trump. It's also the case that you've got to get your hospital system to discipline itself and only charge one rate per hospital. Most hospitals in America charge multiple rates. Depending on who the insurer is, they charge them a different rate. Maryland has already done that. It's a so-called all-payer system. One rate card for each hospital. What's lacking right now is the public will. In Annapolis, amongst elected leaders. But the will amongst the people of the state is shifting in our direction every day. When I rush out of here tonight, I literally will be going over to the Eastern Shore to meet with a man I met when I first started this campaign a few months ago. And I was in a backyard in Talbot, and it had been a rough week. Started off in Montgomery County, 2 young students, Muslim American students, shot 20 times in a car 2 days before graduation. Went to work in Baltimore City, headline read, 5 students, black students buried at one high school this year. Found myself in the backyard in Talbot County. It looks a little bit like the set of the Gilmore Girls or Northern Exposure, very bucolic, far apart from the suffering that dealing with the rest of the week. A little white girl walks up to me, 13 years old, coming from tennis practice, very chipper. Quickly shifts into talking about the 3 classmates that she had to bury this year, the 3 funerals she attended for classmates because they overdosed on opioids. And the need for us to have drug rehabilitation on demand. And it was against that backdrop that I gave like a standard stump speech. And then a man raises his hand and he says, "What do you think of Trump voters?" And I said, "You mean the ones who voted for Obama twice and then voted for Donald Trump?" He said, "Yeah, them." I said, "Well, I spent a year of my life urging people to do something else. But I don't believe that they're crazy if that's what you mean." Because I read the Priorities USA polling that was published after the election that said that voters who voted for Obama twice and voted for Trump tended to be white, tended to be working class, and tended to believe that they had been betrayed by the economy, that what had been a recession for everybody else had become a depression for them, and while they had tried something twice, voting for the Democratic nominee, and now they were trying something else, because that first 2 times hadn't worked as well as they had. I said, I don't think they're crazy, just like I don't think of the black working class voters who voted for Obama and then didn't vote, but that percentage of that group wasn't lazy. Because it's basic human behavior. You try something twice, and if you don't feel like it worked for your family, either you try something else or you just don't do it again. Again, I urge people not to do either of those things, but I don't think one's crazy. I don't think one's lazy. I just think they were a little misguided that day. He said, "Well, thank you for saying that." He said, because I voted for Donald Trump. And as if somebody admitted that in this room, somebody may have, if they did, probably not eager to say it in this room. Everybody just inhaled for a second. Huh? We thought we knew you. We do know you. What? We can talk at what? He said, I had one other question for you. So I said, "What's that?" He said, "Where are you in single payer?" I said, "I'm all for it." He said, "Really?" I said, "Heck yeah." He said, "Well, then I will vote for you, and I will organize other people who voted for Donald Trump to vote for you too." And I said, "Thank you, brother. Now I have a question for you." He said, "What's that?" I said, "Why?" He said, "Well," he said, "it's kind of simple." He said, "I'm a finance manager at a car dealership. And every year I dread the coming of the same day. And like Groundhog Day, it comes every year. It's that day that we find out," headlines last week, that we find out once again our healthcare costs are going up way more than we expected. And then I have to have 2 conversations I hate to have. One is with my boss, the owner, to explain to him that once again we will have to ratchet down everything. Profit projections, bonus projections, everything. And he said, then his voice kind of cracked, and he said, and the others with the employees whom I love. My fellow employees, to explain to them that once again, not only will bonuses be less than we had hoped, but when it comes to health care, they will be paying more, and their families will be getting less. And that's my bottom line. My business doesn't get stronger, and my people don't get healthier until we take the profit motive out of basic health care coverage. And ladies and gentlemen, that's why we'll get it done. We'll get it done because we have allies that we're not even counting right now. We'll get it done because this impacts families across this state. We'll get it done because we filled up an amphitheater in Western Maryland in the last 6 months with 1,000 people at 6 o'clock in the morning seeking free dental care. We'll get it done because after a generation of trying other things that have failed to solve this problem, we are finally at a place where the people of Maryland are ready for us to lead them in building a movement to make sure that everybody in our state has health care, no matter what Donald Trump does in Washington. Thank you for getting ready to organize. Thank you for coming together. Let us commit to make this room bigger and bigger every time. As Martin Luther King told a mentor of mine, if you're comfortable in your coalition is too small. I feel pretty comfortable here today. Let's aspire to build a room that's so robust that all of us feel a little bit out of place, because that's in a democracy when big change happens. And that's why I'm rushing out of here today to go back to see that Trump voter on the Eastern Shore for the first time. He's organized some more Trump voters. And we're getting ready, ladies and gentlemen, not just to win this primary, but to win this general and get Maryland back to a place where the working families of our state govern the priorities of our government. Thank you, and God bless.
This young man is running for governor, but I want to take this time. This isn't I'm not endorsing him for this venture. I do endorse him on my own, but I would say that keep in mind in all that we do, those not only politicians and policymakers and people that are running for office, but keep in mind the people who take time out of their schedule to engage in issues that are important to us. And that's an incredibly powerful thing that we are aware of that, and do not take it lightly. I say that because we've been having forums, the caucus of which I'm secretary, we've been having forums with mayoral candidates, and our current mayor has never once shown up or even filled out questionnaires and given them to us, which is disrespectful to the community to which he serves. So I want to thank you for driving here, coming here on your Sunday, and have a safe day. All right, so moving along, are you all still with us? All right, okay, so let's move forward. I want to introduce right now Chrissy Holt, who has been incredibly important to this issue and a lot of others, and I have a lot of respect for her and for her family. And Chrissy is going to be delving into the healthcare problems and challenges and issues, but also presenting, I believe, as a patient advocate and as someone who deals with this with her family, I believe probably some useful tools as to how to navigate all of these issues that are arising. So, Christy, thank you very much. Christy
So, I'm holding 2 denials from Blue Cross Blue Shield Care First, which is what started this for us a couple of weeks ago. So the essence of where this forum came from and why we came together as the Anne Arundel Indivisible Group and we tapped our friends over at the other two Annapolis coalitions is because Care First was threatening to no longer be a part of the Anne Arundel Medical Center. And we came out very strong against that in August. And luckily there was a confidential settlement, but we don't know what that settlement means to us. We also noticed at the time that Care First Blue Cross Blue Shield was seeking a 50% increase for premiums in 2018. And they were invited to come today. They were invited to come talk to us about that. What would those 50% increase do? What would that do for us as one of their members, one of the 300 million members that Care First Marketplace owns? As you know, they own 75% of the marketplace here in this tri-state area. Right, so I have chronic back pain. They know that, but they still won't let me go to my chiropractor more than 12 times. Continue to push them for extensive care, they will continue to push back in line of profitability, even though they're a nonprofit. Governor Hogan hasn't really touched on the Medicaid expansion, although we did find some literature that suggested he might want to retreat, that he would consider going after that, but he knows he has a Democratic Assembly right now. So part of my presentation and what we're going to talk about is defining the problem, not only here in Maryland, but what's going on in America, and then what now? What are we going to do now? And I am mindful of the time, so this is fantastic. But I'm going to have to talk quickly, and I'm going to skip over some pieces that have already been touched on. So to further define the problem that Eric defined for us a few minutes ago, we all know and can feel that we're spending about $10,000 a year per person. That's twice as much as our counterparts in other countries today, including Canada, the UK, and Germany. For families like us, and I am, many of you have heard me speak before, but my son has severe hemophilia A, and he's 22 years old, and I've been lobbying on his behalf for the last 20 years. He was born in the state of Virginia, where he was uninsurable in the state of Virginia, and we had to move to have our health care covered for him. So to feel the effects of spending about $40,000 a year has been part of our lifestyle when you're dealing with a child with a chronically ill condition that goes through about $250,000 of medication a year, $2,000 a dose every other day. So the brand drugs that we pay for here in the United States is about 50 to 60% higher than our peers in other countries. And as we alluded to earlier, about most of the bankruptcies here in America are because of these medical costs. So healthcare expenditures, I think where I'm going to add value to what our folks were talking about before is I'm going to go deeper into what we are paying today in our public funds. And when we say public funds, remember, that's our tax dollars. We are the ones paying for this. This isn't some nebulous out here, public funds. It's actually our money. So taxpayers right now, of the $2.9 trillion that we spend on health care, we are actually funding 64% of that. And what that means is over 50%, or $900 billion, goes into Medicare, Medicaid, and the VA. Of that, there's still two other categories, and here's a graphic that Art put together for you. So you can see in the blue, right, those are our public funds. We start to get, and it's not great coloring up here, but you'll see the government employers to the private insurers. So that's still our tax dollars going into the private insurer, meaning federal government workers, all of Anne Arundel County teachers, all of our county workers, right? We actually pay with our tax dollars to the private companies. Then there's another aspect of that, which is part of the Affordable Care Act, which are the subsidies that our taxpayers are paying into the private sector for them to benefit. So the smallest portion that the private sector is actually paying is about 25% of the overall number. And still, they can't make it work, and still, we're about to bail them out again. But before we bail them out, I also want to remind you that these for-profit organizations are really well organized, to the tune of $3.4 billion in lobbying against us. Lobbying to prove that they need to maintain their for-profit status or their nonprofit status against us by denying our coverage. We've already heard from Eric that we don't even have great outcomes, right? To the fact that we rank 43 in infant mortality and we have the highest rates of diabetes and obesity globally. Shareholder value and salaries trump paying claims today. That's the model that we live in. Let's go deeper into what's happening in the private sector. Go deeper into the private sector and we look, so remember, we paid $1.9 trillion, and let's talk about what's happening to our money when it actually gets to the other side, when it's actually inside. Beyond the lobbying, we're paying excessive amounts for their compensation. So this is just how much they get paid, right? So Michael makes $22 million at Centene. Bruce at Humana, who runs a large portion of our Medicare program, makes $19 million. Mark at Aetna makes $18 million, right? And that's only a small part of the actual overall compensation breakdown that these guys are making. You know, you sort of wonder what's going on with David at Cigna. He's only making $15 million. He should have been able to negotiate a better salary than that. But maybe he'll make it up in his stock. So one of the things that I did this morning over coffee was to take the number of shares per million that they have per company, and I multiplied that by their closing stock price from Friday afternoon. And so what they resulted in is the cash value of their stock, and we kept doing the math over and over again going, is that in the billions? Is that in the billions? These guys make between $50,000 to $60,000 a day. These are the guys that are running our health insurance industry today. So if you're upset about like that, the way that we were really upset about that this morning, you'd want to pick up the phone and call your congressional folks, right? And say, we need a better way, right? Eric and Margaret and Rob, these guys have been doing this for years. I've been doing it on the patient side for years, right? And this is what we got from congressional this year. The congressional outlook is, hey, we need to stabilize this market. The insurance companies sort of can't figure it out anymore, and they need continued bailouts from us. And so what we've been hearing for a long time this year, and we're going to hear it again because they're starting to put it together, is that we need to stabilize this market, and the net result of that are uninsured citizens. Luckily, they have failed to this point. So we would submit and continue to submit that we need to shift this conversation. It's not about stabilizing the health insurance industry. It's about providing health care for Americans. There are 4 ways that we can divide this up, and we do have some sheets for you out in the back. There's 2 types of single payer. There's the public funds and privately delivered, or public funds and publicly delivered. What we're talking about is the public funds and having it privately delivered. So for the sake of time, I'm going to keep going. But in this bottom quadrant here, we want to just emphasize that we have public funds going to private companies. And that's why profitability is leaking out the other side. What we want to do is stop that process. And you can see Germany's done that because they wouldn't let them be profitable, a for-profit organization. They at least at a minimum made them nonprofit, right? But in our market right now, that money is going out the other side. So the Affordable Care Act came into place. It was perceived by the chronically ill that it was a step in the right direction. There are rights that the Affordable Care Act and Obamacare were to help us with. The main ones that we focused on in the hemophilia community, you know, the pre-existing condition. Again, my son was born uninsurable, and when he marches today, he carries that sign, I'm uninsurable, or I have a pre-existing condition. He will definitely be discriminated against in the workforce if he was to tell anybody that he has that, because of course in this model today, he could drain their health insurance, savings, or however that organization is insured. My goal as his mom, right, is that I have 4 years until he's going to roll off. He'll be 26 years old, and right now you can have your children stay on your plan until they're 26. But once he's off my plan, then he rolls into the category of the unknown, where a lot of the hemophilia community has landed through the years. So I'm going to keep going on the two pieces that were imperative to the Affordable Care Act that were helpful were the essential benefits. And this has been the sort of the shiny penny that the Senate tried to sort of mix up the conversation over the last few months, was to say, hey, we're still holding on to no lifetime caps, no pre-existing condition, and your kid can still stay on your plan until you're 26, but we're going to wipe out all the essential benefits. And all the essential benefits of the hospitalization, ambulatory care, prescriptions, all the pieces and parts that you actually want to have the payment for. If they strip all of that out, then those three don't even actually make sense, because you're still paying cash for your health care. We saw a decline with the Affordable Care Act, but it's not done yet. But there are some benefits that came out of that. Maryland certainly benefited from the expansion, as well as the hemophilia population. They expanded it to include men and women, childless men and women, so that they could have access to this plan. Really helped our community a lot. Some of the biggest flaws, though, is that we had to again bail out our insurers last year for $300 billion. I mean, they could have just written that check themselves, right, for how much money these guys make. Not to keep reiterating the same piece, but it's just got to be said that we're wasting billions of dollars on lobbying against us, on advertising, on redundant administration, and clearly public option's not an option. You're going to start hearing this from our representatives today. We would argue that this is just a wasted step in the process. What it might do is slow things down a little bit, so maybe we can capture the House of Representatives or the Senate again. Remember, I'm a mom. I don't do this for a living, but this is just what I've been trying to figure out. But for the most part, we don't think that this is the way to do it, and it will continue to be a failed approach, because competition doesn't necessarily drive down costs overall. It's unpredictable to know what your illness and what your accident might be if you did go for the public option. Private insurance companies would probably cherry pick the healthy, which would then bankrupt the public option, which would be there as your safety net for your poor, your sick, and your old. And at the end of the day, the public option is only available on exchanges. So for folks that are employed, that's not an option that I would go for, because it's not even available to me through my employer. So it's not a solve, it's a step, but it's not where we need to go. So to continue this, we know that it's a step, but it is a grassroots effort. Now more than ever, we need all of us to take this presentation, share it with your families, have a potluck, bring your friends over, and walk them through. We need to educate each other and understand what we're talking about, so that when these bills come to life, then you and your friends will encourage the legislators to do the right thing for the American people. Right now, we have H.R. 676 that's on the floor. It is a public finance private delivery bill. You can see that Elijah's already signed on to it, Raskin, Brown, and Sarbanes. This bill's been introduced for the last 10 years. This is not new news, okay? The Affordable Care Act was a step, but this is where we need to be going. So who's missing from that list in our Maryland? We need to call them. Steny Horner, we need Harris, Delaney, Rupersberger. We need the entire Maryland contingent to sign on to this. So think about what you're going to do when you leave today to contact these people to go ahead and sign this bill. Then on the Senate side, thank God the skinny bill died. And because I do lobby every year on Capitol Hill, I literally called Senator Cardin's office and Senator Van Hollen's office and cried on the phone with their health care exec. I was like, how is it possible 20 years later that we are having a bill that's going to throw the chronically ill out on the street again? Why are we having this conversation in 2017? So Bernie Sanders is expected to drop the Medicare for All bill this Wednesday, September 13th. You are in the moment right now in the legislative cycle. This is huge. We need to go out to the Bernie Sanders website. He wants us to sign up as a citizen to co-sponsor. So sign yourself up, sign everybody up in your family, because he needs that energy, right? We need the Senate to have that energy that the people are behind this, and we want this bill to go. So here's what we're going to do. What now? This is the call to action. You're going to call your congressional member. You're going to thank, if Sarbanes is your congressperson, thank you for doing the right thing. Then we're going to call Senator Cardin. We're going to call Senators Van Hollen. Van Hollen is having a health care forum next week, next Saturday, September 16th. Art and I are going. We're happy to drive people. If you can't go, we'll come pick you up. But we need to go because they're out talking about public option, and that's not what we want. What we want is Medicare for all. So you're going to call your friends and family in those Republican states. Think about, we have family in Colorado. We call them all the time. Call your senator. Tell them to do the right thing. This is part of that grassroots effort. So you educate yourself, and then you call your friends and family. You take our presentations, you take all of our contact information, and you share it with the next person. This is grassroots. This is how we're going to get it. We're going to sign up with our citizens to co-sponsor, and then we would encourage you to participate in our groups. Be an advocate. Join us. We are, when there's something to march on, then we're going down there. Healthcare is a human right. We are out there marching. Masses help, community help, we can all do it together. So these are the next action steps for you to take, and immediately we need for you to call these folks. So with that, I think we are getting close to giving it to Will. We have 2 more quick speakers, and we are going to do an open mic. Thank you.
Thank you. All right. Okay, so keeping it moving, our next speaker is Dr. Margaret Flowers, MD, who's part of the Leadership Council. Healthcare is a human right, also in Maryland, co-chair for Physicians for a National Health Program. This goes on and on. Maryland chapter, steering committee, and there's literally an entire quarter page of credentials for her. And so what we can know is that she's probably going to be chock full of good information. Thank you for being here. I want to add one part to it that I thought was interesting is that she practiced pediatrics in Maryland for 17 years. So she has experience also as a hospitalist at a rural hospital and in private practice. So Dr. Margaret Flowers. Thank you.
Okay, so I don't have a... You can rest your eyes. You don't have to look up there anymore. You can just look right here. So I'm going to share a few thoughts with you, and then I want to go into more concretely what we can do from here. I practiced pediatrics for 17 years. I stopped in 2007. I was really frustrated with the way that the healthcare system wasn't working. I was sad to see so many of my colleagues leaving practice because they were similarly getting frustrated, and I felt like most of them were the ones I thought were the really great docs who cared about their patients. Physician burnout is the #2 problem that was identified by the last Surgeon General. As you know, #1 was the opioid epidemic, and #2 is we're losing physicians because of this current system. So when I didn't really have in mind, I didn't really know what the solution was. I just knew what the problems were, and so I spent a number of years trying to figure out what was going on, and really was convinced at the end of that time that we need a national improved Medicare for all, or a national health service. I would also support that. We see national improved Medicare for all as the compromise from a national health service. This is the smallest step that we can take to get the money that we need to pay for everybody and to have a healthcare system that has health as the bottom line, not profit. And that's why we started Health Over Profit for Everyone. The organization is healthoverprofit.org. So National Improved Medicare for All as embodied in HR 676. If you want to know a simple way to talk about it, just break it down. It's national. Every person living in the United States Every health professional in the United States is in the system, and you get care from the time that you're born until you die wherever you go. It's improved because we get rid of the co-pays and deductibles and the premiums, and we also make it more comprehensive. And then it's Medicare for all, so like Medicare, it's financed through taxes, and we recommend a progressive tax is what's being looked at. Robert mentioned David Barton Smith, and he has a really great book that's out right now. It's a new book, and it's called The Power to Heal, Medicare, Civil Rights, and the Struggle to Transform Health in the United States, or in America, I can't remember which he says. But it's really interesting because it looks at that past 100 years and those 5 different phases, and each one of those were a compromise. For those 100 years, there was a movement for national improved, some sort of national health insurance, but every time they decided to compromise. And Medicare and Medicaid in 1965 was a compromise from that national health insurance. And racism has played a role throughout this entire time. It's interesting. Wilbur Mills, who was head of the Ways and Means Committee in the House, he was a Southern Dixiecrat, he put a poison pill into that Medicare bill that prevented it from being expanded to everyone. Barton Smith writes about this. By making it a tiered system, he called it a 3-layered cake. And it was Medicare Part A, Medicare Part B, and Medicaid. Instead of being one system, by making them 3, it was much more difficult to expand that into a universal system. And then we get the other compromises that were made after that. So it's important to get that history, and I think if you read his book, to me, I knew that there was severe segregation and standing in this place, that was founded during segregation in our healthcare system, but literally the amount of cruelty, the turning away people from doors, putting hospital beds for African Americans in the basement of the hospital, and if more people showed up and beds were there, literally they were turned out the door regardless of what their situation was or how far they would have to go to get treatment, and there were many deaths because of that. So we have to understand these things and understand that when we win National Improved Medicare for All, not only are we saying that people are more important than corporate profits, because the power of corporate profits is such a powerful force right now, but we're also saying that every single person in the United States deserves the same high-quality standard of health care, and that will go a long way to creating that social solidarity and that empowerment that we need so that we can fight for so many of the other things that we need to be fighting for. So, Chrissy did a great job of telling you what HR 676 is. The number of co-sponsors that we have is record. It's been introduced every session since 2003. And the highest number we had before was like 92. And it's really because of grassroots pressure this year that more and more people have been coming on board. Our last signer, Brad Sherman out in California, he was confronted during a town hall by one of our advocates who's very powerful, and she did her work to get it out everywhere and get everybody calling his office, and within like a few days he signed on. So that's the kind of work that we need to be doing, hounding our members of Congress. Sanders' bill, I was actually in the Senate on Wednesday. It was the Senate Help Committee, Health, Education, Labor, and Pension Committee is holding 4 days of hearings on this bipartisan Premium Stabilization or Market Stabilization and Premium Reduction Act. It was interesting because the Center for American Progress, which is a think tank, it's aligned with the Democratic Party, but it's funded in part by the health insurance lobbyists, and they put out their bipartisan proposal. And it's more bailouts for the health insurance industries. It's more subsidies, more reinsurance, and while private insurers couldn't drop individual patients because of pre-existing conditions, they're allowed to drop geographic regions if they're not profitable enough. So a lot of insurers have been pulling out of different geographic regions. Now we want to give them tax incentives to go back in. It's really just more and more money into those pockets and hoping some of it will trickle down to actually paying for care. So that was a really hard hearing to sit through because every member of Congress, from the Democrats to the Republicans, was just fawning over how much more money we could give to the private insurance industry and how important the market is. And I felt like standing up and screaming, healthcare is not a commodity. It doesn't belong in the market. This is a ridiculous conversation. Can any of you hear that? So after that, we met with Senator Sanders' staff for about an hour and a half to talk about what's in his legislation. Because we've been hearing some things. Sanders is interesting. He told the movement in November after the election that he was not going to introduce a single-payer bill. He said we have to focus on Democratic Party unity and this is a divisive issue, and so there won't be a bill. And we said, that's not cool with us. You campaigned on this, and we need it, and now is the time. And so people started calling his office, and we put a lot of pressure on him, and he said, okay, I'll do a bill. But this is the role that we have to think of as activists, and I'll go into that in a little bit more, is that we have to be watching very carefully and making sure that what we're getting is what we want, because we know that those billions of dollars of lobbyists are being spent to try to convince our Congress members to go in a different way. So we were hearing some things from his legislation that we weren't very comfortable with. We met with his staff. They wouldn't show us the text. There were some things that were reassuring. It's going to be fairly comprehensive. It is including full reproductive rights for women, which is important. It's also, he got a lot of pushback for wanting to put co-pays in there. So he's taking the co-pays out, except for some pharmaceuticals, to encourage generics. But apparently physicians can waive that if it's a hardship. The other thing that was good is he's not allowing private insurers to duplicate what the system covers. So that, we do have moved towards a single payer system. Some of the things that we weren't too happy about is he's not including long-term care. And this is a huge one for, our movement activists. He also is allowing, and this is a tough one, he's saying that you can't prevent health professionals from opting out of the system and taking cash. Our concern is we'd like to find a way to prevent that, because we do not want a tiered system. We do not want the wealthy being able to go to private hospitals and pay for the cash for their care, and then they get a really great, cushy system, and we get what's left over. The other thing, let's see, I made notes so I wouldn't forget it. He's allowing for-profit, investor-owned health facilities to continue to operate. HR 676 bans those. So things like these kidney dialysis centers that operate for profit, and so basically they churn through people, they don't give them their full treatments, they don't clean the equipment well between patients because their incentive is to churn people through, they don't actually care about how they do. It's just, they're just widgets, right, coming through. The more widgets, the more money you make. So we weren't happy about that, and then also he wants to do a 4-year transition, and we feel like we should do a much shorter transition. We feel like that's an opportunity for the system to become undermined. So that's Sanders' bill. Okay, so in 2009, 2010, I volunteered as a congressional fellow for Physicians for National Health Program. I basically spent most of my time down in Congress trying to push members of Congress to talk about single payer. We were part of a very broad coalition. It was called the Leadership Conference for Guaranteed Health Care. It was union groups, faith groups, community groups, health professionals, and we were in there meeting with members of Congress and saying, as you go forward, just compare what you're putting together to our proposal on the basis of how many people are covered and how much it costs, because we knew that we would be superior. And what we found was, whether you're Democrat or Republican, they did not want us to be testifying in their hearings. They did not want that information to be available because they had already decided the path that they wanted, and so they were shutting our voices out. I came out of that experience with 3 lessons for us if we want to win this. And it has the acronym ICU, which is, you can think we're in a healthcare crisis and we need an ICU, or an intensive care unit. But this stands for, the I is for independence. We have to recognize that our issue is to win a universal, publicly financed healthcare system in the United States. We cannot tie it to the agenda of a political party or a particular politician, because when we do that, we start to compromise ourselves immediately. Their job is to do what we want. Our job is not to be like, okay, we trust you'll do everything right, even with all those lobbyists whispering in your ears. We can't do that. The C stands for clarity. We have to understand what works and what doesn't work. There are all kinds of incremental measures that are being posted right now. Right after the repeal and replace effort failed, all of a sudden there were all these articles by prominent progressives in The Nation and The Hill and Salon and other outlets saying, I'm a big fan of single payer, but we can't do that. It's too much. Or we have this other way, and it's a back door, and it will get us there, and it'll be easier and more politically feasible. So we have to understand what works and what doesn't. And this is why I say the smallest incremental step is a single payer system. We have a lot of work to do beyond that, but this makes the bottom line health and not profit. And so we can do those things if we make that fundamental change. And then the U stands for uncompromising. Gandhi has a quote where he said that you can't compromise on fundamentals because it's all give and no take. So we are being asked to compromise on something that every other country has, that we're already paying for, and we should have today. And when they tell us that we have to compromise, what they're telling us is they're trying to take our power away. They're telling us we're asking for too much. We are not. Every movement has been told that it was asking for too much. All right, so I think I should wrap up. Things that you can do. So Health Over Profit is basically a website, healthoverprofit.org, that has tools for activists. And I'm also active with the Healthcare is a Human Right campaign, and I really urge you to get involved in that here in Maryland. We do calls every other Monday night, educational calls, national calls. The next one is tomorrow at 9 p.m. We have citizen lobbyists who are developing relationships with their members of Congress and sending them information because they don't know about. Their health staffers don't understand what we're talking about. This is new to them. So we need to educate them. Go after the 4 members of the House here in Maryland. And we're not endorsing Sanders' bill until we read it. We as a group have to read it and discuss it and analyze it and decide what is the most strategic thing for us to do. We tend to push on things to make them better. Labor unions, we have resources. There are over 600 labor unions that have signed on to HR 676, so we have information where you can find out who those are and how to get your labor on if they aren't. And then business leaders. There's a new group called Business Leaders Transforming Healthcare. They have some movies, 2 really excellent movies that you can show in your community. Businesses can sign on. They have talking points, and we have some of those materials on our website as well so that you can reach out to friends who own businesses. Basically, it's going to come down to us creating a movement of movements because healthcare touches everything. And that's very clear and uncompromising in our demand for national improved Medicare for all. Thanks.
Thank you. And again, we apologize. If it seems kind of rushed, we do apologize because we have a chock full. And I want to also mention that as we close, some of our speakers will hopefully be here for a little while. So that's an opportunity for you all if you have additional questions and you want more information or you want to find out how you can join and support all of these efforts. Our next speaker is going to be Teresa Black, and please come. She's a naval officer and an advocate for the people. Thank you very much.
Not too long ago, I was speaking to a seasoned mother of 3 who was having a healthcare dilemma. She had, as I said, 3 children, and her 2 oldest are in their late teens, and their health insurance is covered by their father's plan. But she, her husband, and her little baby, her baby child, who is 6 years old, are uninsured. See, they make too much money for their son to qualify under CHIP. And they also make too much money for them to qualify under Medicaid. Now, they both work full-time jobs, but after paying for the mortgage for a home that is large enough to house 5 individuals that are in their family and paying other family expenses, they have no money left over for health insurance for their child. Now, their son has ADD, and he recently started at a new school, and he was having problems. And instead of giving him the support he needed at that school, they required documentation that was recent, documenting his ADD. And unable to go to the doctor because they had no health insurance and unable to pay out of pocket, their son began to do worse and worse in school and began to hate going to school every day. And as a result, this brought great stress upon her. We're living in an era, the era of the Affordable Care Act, and millions are falling through the cracks, like this family that I was just speaking of. The Affordable Care Act was a huge step in the right direction, But the problem is that when your final destination is healthcare that is affordable for everyone who wants it, one huge step is not going to get us where we need to go. Right now, it seems as though health insurance providers have a hold and are completely in control of our health insurance system, our healthcare system, which is obviously a horrible problem. They're acting as grim reapers and oftentimes deciding who lives and dies based on who has the ability to pay them. Recently, Maryland went through a situation where First Choice Blue Cross Blue Shield was threatening to get rid of the service providers for many Marylanders. Mind you, they made $8.8 million and billion in profits in 2016 and paid their executives over $100 million. And yet they were threatening to take away services because of $13 million. This is mere pennies to them. They obviously don't care about the people and are leaving us out to dry. It's time that we do the same to them. We need to continue to fight for what we need, and we need a healthcare system that covers everyone. As you heard earlier, this week, a healthcare for all bill is going to be introduced into the Senate. And as she also said earlier, I am not telling you to support this bill. I'm not even asking you to support this bill. I am asking you to read it. And if you do support what it says in that bill, you need to call our senators and ask them to support it. We need to tell them our stories. We need to show them our pictures and let them know that the Affordable Care Act is not enough and we need more. We need to remind them that we are in control, and we need to give them a list of our demands. We need to demand to live without fear that we will become homeless, die, or go bankrupt because of an illness. We need to demand that greed be eliminated as a factor in our healthcare debate. We need to demand that our children, women, and men are covered under a quality healthcare program. We can no longer let them do what they want and as they please. We need to flex our muscles. We, the people, elect them. We, the people, are in actual control. We need to take that back.
Okay. That was your... This mic, it's weird when mics do that, huh? Okay, so I apologize if it hurt you all's ears. Our next speaker is Eve Hurwitz, who's co-chair of Take Action Anne Arundel County, also the director of March on Maryland, and also the director, a veteran, and a mother, and a local business owner, as well as director of the Milky Way Foundation. I bring you Eve.
Hello. Thank you so much for hanging in there. I'm going to make this quick. I did have like a long thing, and I got it down to these bullet points, so it'll be quick. Okay. So I'm going to start at the beginning, literally, the beginning of our galaxy and the beginning of human life as we know it. That is not what I meant specifically. Looking over here. Okay, so just by a show of hands, does anybody know the Greek mythology story behind the creation of the Milky Way? One person, excellent. Anyone else? That is telling. Thank you, I'm going to talk to you about that later. We're going to tell you the story right now, but just keep in mind only one person knows that story. So Zeus and Hera were a thing. Zeus went off and had a baby with a human, therefore was a demigod. However, Zeus wanted Heracles, the baby was Heracles, Zeus wanted Heracles to have full god powers. So while Hera was sleeping, Zeus put Heracles on her breast to get the milk from her breast and therefore get godlike powers. Hera woke up to an unknown baby at her breast, and the resulting milk made the Milky Way galaxy. That's been around for millennia. That is how the Milky Way got its name. That story has been around for thousands of years. If men breastfed, we would have walls and plaques and statues and whole buildings to that story. The reason I tell you this is because we need to elevate mothers, elevate women, take care of our families. We have a problem in this country and in the world. Breastfeeding and skin-to-skin contact right after birth is essential. It's not about the food, it's about this much about the actual sustenance. It's about neurons that don't ever develop when a baby does not breastfeed or have skin-to-skin contact. It's about the intrinsic self-worth that goes away when breastfeeding doesn't happen, when skin-to-skin contact doesn't happen, when we listen to doctors who are still telling mothers to let their babies cry it out. And here's the problem. We have women, 25% of American mothers go back to work 2 weeks after giving birth. Our country is one of only 3 countries in the entire world, 172 countries. There are 3 countries that have no national paid leave program. There's Papua New Guinea, Suriname, and the United States. That's it. We have no national paid leave program. What does that do to our next generation when mothers are going back to work? When they're letting their children cry it out because they are so exhausted, they go, you know what, I'm going to listen to that doctor because I have to get up at 6 o'clock to go to work, and I'm still healing. My incision is still bleeding, but I have to go to work. We've got to change this. And there is legislation in Congress called the Family Act that nobody knows about because they've buried it. Because God forbid we do anything, we ask businesses to do anything that's going to take care of our families. I'm a business owner. I own the QuickBooks Badass, QBBadass.com. I give paid leave to my employees because that is what is important. We need to take care of our families, right? When we tell our employees and our families that they need to go to work instead of taking care of our families, it sends a message that work is more important and money's more important. And that is the message that we send with all of this. What was this theme that we heard all day today? Money, 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 money. It's our time to tell the people who lead us, it's not money, it's health, it's happiness. I'm going to start calling something called the Pursuit of Happiness Act that I'll get into another time, which is about health and wellness in a very real sense of the word, taking care of ourselves and our families. Getting off track. Okay, so I'm going to transition now. That was my little paid leave spiel that I'm going to get into the military. So when I was active duty, I actually had paid leave. I had 6 weeks at the time. Since then, Senator Tammy Duckworth, who is one of my mentors, and an amazing woman, got 12 weeks for the military mothers, 12 weeks paid leave. We, again, as citizens, civilians, have 0. Military members are not better people than civilians. They just do a different sacrifice. As military members, we are trained to call every civilian ma'am and sir, because a civilian outranks us. You are ma'am, you are sir. That should translate to how we treat our citizens. Every citizen deserves the security, the stability, and the sense of well-being that I had when I was active duty, knowing I was completely covered. No COVID. Everything was covered. I was taken care of. I didn't even think about it. That's what Americans deserve, that if you're sick, you don't even worry about it. You just go to the doctor. My medical records followed me wherever I went. Everywhere I went, I had a place to go to get care. That's what we need. We need TRICARE for all. It's called TRICARE, the health care that military has. And TRICARE for all is what we need. Medicare for all is a step in the right direction. We need TRICARE for all, because Medicare for all is still a form of insurance. We need health care, not insurance. We need to get rid of insurance companies. We just need them to go away. They take our money and they spend it on themselves. We need to get the money out of health care and bring the health back in health care. It is extremely important. And you know what? I am going to join that Business Leaders Transforming Healthcare thing. I'm really excited about that. Thank you for bringing that up. And I'm actually going to stop there because we are over time. Please feel free to reach out. eve33.com is my website. I have a lot more to say. I could go on forever. I would love to talk to anybody. And my last little plug, you can't talk about healthcare without talking about medical marijuana. And that's going to be the next subject when we talk about healthcare, because you have to talk about that.
All right, so this has been awesome. I want to give another personal plug to Eve and her family, because I think it's always awesome when someone shows up to meetings and public things with their family and their small children. And it's interesting how some people react to that, but it says a lot about our society as well as some of our larger systems where they're not conducive to families. It gets to be kind of, to me, it gets to be a bit of a conflict. What people are telling us is important to them when they don't support that. So I want to doubly, And part of it is because before I moved back to Annapolis, I worked for 7 years for a state commission, a public commission called First 5 LA. And if any of you all don't know about First 5 LA, in California, we have universal preschool. And it's called First 5 because it's important that the first 5 years of life are some of the most, but also a lot of the other skills. And it's an indicator for other things, not just education, but literally everything else. And we've been pushing for that in Maryland in private conversations because our policymakers don't even consider the fact that supporting families begins with supporting prenatal, early childhood education, all those things, not separating them out. So I applaud you for that. Now we want to open up the floor. That was also a little side note about California and forcing our policymakers to put stuff on the ballot because we have propositions. So stay on the fight. If there's any questions, we want to have a small question session in lieu of time. But are there any questions in the audience? And I'll direct them where you need them to be directed to. So, ma'am?
I understand that with health care here in Maryland that we do have 2 bills for health care. When you apply to be a demonstration, you do that through the Centers for Medicare and Medicaid Services, and you have to demonstrate under 1115 waiver, budget neutrality and cost savings. So what types of research has the state of Maryland done to prove that this demonstration would be cost neutral and save money so that the Centers for Medicare and Medicaid Service as well and the Secretary of Health and Human Services would actually approve such a demonstration?
That is an incredibly powerful question. I have a couple questions to add to that. Who feels that they're in a position to answer that question? There you go. Do you want to come up here? Oh, also, before you leave, hold on 1 second. Before you leave, Andrew is from Sarbanes' office, and so we do have a representative from Sarbanes' office, and I want to thank you so much for being here. Distill that question. Do you have an answer to this?
I have sort of an answer, but I have a question for you first, which is, Margaret and I and some other people worked on a single payer bill called the Maryland Health Security Act up until 2012, and I'm just wondering if that's what you're referring to, or you're referring to somebody else.
Well, I'm just reading here where you're, let me see, SB 206 and HB 1015, and that, you have the study models, and then I signed petitions back there about a demonstration waiver so that the state of Maryland has a single payer system.
Right. Do you recall who sponsored that?
I haven't recognized those numbers. That's the bill that we worked. That's the Maryland Health Security Act. We haven't introduced that since, it hasn't been introduced since 2012.
So I guess my question
There's no active legislation at the moment.
is the state of Maryland going to go forward with a single payer system?
So can Maryland move forward as a demonstration project as a state single-payer system? And that was one thing I didn't have time to address in my talk. We initially, and I helped to write that legislation years ago, we had the goal of attempting state single-payer, and I disagree with Ben Jealous. Public Citizen did a really excellent report where they call it a roadmap to single-payer at the state level, where they show that you can get close but you can't get a pure single-payer system at the state level. There are too many barriers, there's too many moving pieces, and I don't agree with Ben Jealous that our current waivers would allow us to do that. And so if we're going to have to go through a federal fight to get the changes to the laws that we need in order to try to do a pure state single-payer system, we would rather take that federal fight to fight for a national improved Medicare for all. My family is very spread out. My children are all over the place, and my brothers and sisters, and my nieces and nephews, and grandnieces and nephews. Everyone needs to have access to health care. So we've decided as Healthcare is a Human Right Maryland to put our energy and resources into fighting for a national improved Medicare for all. And we believe now is the time to do that. There's tremendous momentum at the grassroots level for that. That's been dead for years. Yeah, we did do the economic study, which Eric could speak to. We raised the money and did the study.
My very long CV, but we did do a study back in 2012 modeling that bill. It showed significant savings.
If it could have been.
If it could have been pure, but if it could have been done ideally, but the 1115 waivers, there's no. Vermont was a state that was going for that, and their parts of they never, even when the Obama administration, they never got an answer to their application.
Right. With the current administration, I would think the application would not happen, but I know the state of California is pursuing something like this now. So I'm just wondering if, during the fight for a national health care system, everyone should pursue.
People often point to the example of Canada and how the Canadian system started in one province and then spread to the rest of the country. That was in they copied ours. That was the 1970s? Late 60s? Yeah, early 60s. They were in a very different situation. They didn't face the federal hurdles that we face here in the United States. So our belief is that we can't get a pure state single-payer system, that calling it a single-payer system when it's not a single-payer system sets us up for problems, because if it doesn't get the savings of a single-payer system, then it may fail, and then people will get the message that single-payer doesn't work. So we're focused primarily solely right now at the national level. And it's interesting because Jealous mentioned state single payer. Nancy Pelosi, her response, because she doesn't support single payer, and she said, do it at the states first. And that's one of those, don't talk to us in Congress because you got to go do it at the state first. And that's an excuse to throw us off track and keep us from fighting for it at the national level.
Again, they may be trying to leave soon, but we're going to have a Q&A until about 7:30. Can't leave until. Are there any other questions? Oh, I'm sorry. I apologize for that. You can come further forward if you want, but if your voice carries, we might be able to.
Talk about it not being a complete single-payer system or the possibility of some aspect of privatization, and you see people who are already trapped there in the current system. The free clinics, some of the military who say they don't have flexibility in care, they're not able to get all the services they want, they're not able to get all the dental help that they want or medications that they need. So if there are these sort of loopholes where you're able to buy your way out of it, then how do those people who have critically ill family members not get trapped outside of the innovation and the services, that we currently that we can currently access through, we pay a lot of money every month for a PPO so that we can go somewhere without you getting to tell us if we can go. And they would love for us probably to walk away from our health insurance, but because it costs them so much money. But what I'm worried about is if it's not completely across the board, how will it not be the same? How will you actually not put more people in a position of having less flexibility?
So
that there are tens of millions of people in the United States who have no access, no health insurance at all. And tens of millions of people who have health insurance but they can't use it because they don't have the money to afford the deductibles. So we have a pretty bad situation. HR 676, if it were passed as it is now, and this is a bill that came out of the movement, and a lot of this was developed as consensus in the movement of what we want to see going forward, would cover every person living in the United States, whether they have documents or not, from prenatal care to death, with comprehensive benefits, and the decisions are made by health professionals and their patients on what is medically necessary care, but it would cover inpatient, outpatient, emergency care, pharmaceuticals, medical devices, hearing, dental, vision, mental health, substance abuse, long-term rehabilitation. It's very comprehensive because if we have a healthcare system that's very comprehensive and people don't need supplemental insurance or need to buy out of the system, that's the most efficient health system that we can have. The simplest, right? Now, Senator Sanders' bill does allow people to opt out of the system, and so that's one of our critiques of it. And it doesn't include long-term care. And we did an email blast out to our list yesterday saying, this is what we found in the bill, and how do you feel about that? And the response we got immediately was all of these stories about why long-term care is critical. So I think we're going to be fighting to make sure that that's included. But the reassuring thing that his staff told us, and we haven't seen the legislation, is that every person in the United States would get a Medicare card, and they would be able to go where they want to go, and that even people who have VA benefits and Indian Health Service benefits would still have that Medicare card, and could choose to seek their care within the VA or IHS, or could choose to seek their care outside of it. So that was reassuring to us. The big problem for us was a 4-year transition, where they're talking about enhancing benefits for Medicare beneficiaries right away to the expanded benefits. That's great. Creating a federal program for youth, like our CHIP program, but federal so that all the youth are in. And then slowly closing that gap somehow to make it a universal system. Our concern is that you're not going to get the cost savings you need during that period to cover everybody. And that, to us, just feels like it's going to create this huge fiasco and all these opportunities for there to be criticism of the system, because it's still really complex, as opposed to every other country and how we did it with Medicare when we decided on this certain date, January 1st of this certain year, everybody has their card and they're in the system. Because we already have a framework. Every health professional in the United States has a Medicare, Medicaid provider number, right? So we already have that network to be able to pay.
And they take Medicare too?
Yeah. And I agree, a national health service would be ideal, but yeah.
You have two bills. One is in the House and one is in the Senate. So
right.
You're saying the one in the House is a better bill than the one you Sanders bill upstate.
We've been pushing Sanders to do the Senate companion of HR 676 all year. Okay. And he's moved a lot in that direction, but we got to keep pushing for it.
Support his bill. Really, we want you to go in the direction of HR 676.
And that's what we've been doing, yeah. And if you go to Health Over Profit, there's tools there to help you do that.
Okay, so then you're saying that the House bill, because our current health system keeps the sick and the uninsured sick.
Yeah, so just to be clear, this is
it keeps the poor and the sick at a certain level, and this is not going to just add even
This House bill would replace everything we have right now,
right,
and create a system that every single person living in the United States would be in that system.
So it would eliminate the tiers that currently.
There would be no tiers.
We don't have.
There would be a single standard of care for every single person. There would be no co-pays, no deductibles, nothing to keep you from seeking care when you need it. It would be one transparent set of rules so that patients know what the rules are and doctors know what the rules are. Right now, we spend tremendous amount of time just trying to figure out what the heck is going on and who can get what and who can go where, and when we should be concentrating on our patients.
Besides Googling and getting a copy of HR 676, do you have it on the table back here? Or?
If you go to healthoverprofit.org, we have links to it there, but you can also just Google it and find it. Thomas.loc.gov is the website that posts all of the legislation, who the co-sponsors are, text of the legislation summaries, where it is in the process. And so we want to get, and it's great that Senator Sarbanes-Stafford came, because he just signed on this year and he's become a stronger proponent, which is excellent. But we need to get, the belief is that a lot of Democrats have signed on right now because it's a hot issue with the public and especially Democratic voters, and they believe that with the Trump administration it's not going to go anywhere, so it's pretty safe to put their name on that right now. And so a lot of them put their name on, but they're not doing anything more than that. And so we need to get our members of Congress to put it on their website that they signed on and what it is. They need to be speaking about it. They need to be holding town halls. They need to be writing op-eds. We need to activate them and show that putting your name on is just not sufficient. So.
Thank you.
Yeah. My question is for you. So I randomly hired HR 676, but I had some issues with it personally. One being that it said that they were going to pay doctors just based off of their specialty as opposed to, and not take into account their region, which I didn't think made any sense because there's going to be different regions where you're going to need more money in order to survive. And then there's a part about that bill where it, well, it's not necessarily a part of the bill, it's absent from the bill, some type of accountability system so that doctors are being held accountable and also rewarded for doing their jobs well. So that doctors don't start to fall off just because they're getting paid no matter what. So why provide an extra service or why go the extra mile? And that was missing, I thought, from that. And so those were I had a couple more issues, but I don't have them on me right now. But
I'll give you my email and we can communicate. Okay. So it creates a board to oversee the system that will help to determine what the payment rates are, and a lot of that will be done in collaboration with, various physician groups to talk about what their needs are. So I'll have to go back. I didn't see where it said flat rate, not based on regional, prices or anything like that. But the intention is, I've spent a lot of time with John Conyers over the years and talking to his staff. The intention is that right now we have a reverse system. We have very few primary care providers and a lot of specialists. And so we definitely want to include incentives to bring more people into primary care to support medical education, because our medical education has become so expensive that only privileged people can become doctors. I'm the youngest of 5 children to a single mom. Nobody in my family's ever been in medicine. My sisters didn't even graduate from high school. But I was able to put myself through college and medical school because when I was doing that, it wasn't that expensive. I went to state schools, right? Now, you can only get in there if you're fairly privileged or willing to take on $200,000 or $300,000 worth of medical student debt. What was the other question? Regional and then?
It was about...
Oh, the incentives. Yeah, so accountability comes through having a system where you can actually now see, you can get all the information, because our system, a lot of that information is proprietary and private. I mean, one example this year was that Medicare Advantage plans, which are private insurance plans, there was an effort to get access to all of their data to see how they're spending the money that we're giving them. And the studiers were really excited about being able to get into that data. And the private Medicare Advantage plans sent their lobbyists in to CMS or Congress or whatever and suppressed that data. So we don't even know how our public dollars are being spent on these private Medicare Advantage plans. When we have a public system, we're going to have all that information. And like what other countries do is they look at outcomes, they look at individual providers, what their outcomes are, what they're doing, and you can start to see the outliers and deal with those. In Canada, they deal with them by, if they find somebody who's deficient in a particular area, then they force them to do more training in that area. They support them. They know that it takes a lot of work to get someone into being a health professional, and they don't want to just kick them out because they may be lacking a skill. The pay-to-play kind of thing that we have right now, where pay for performance, is actually forcing health professionals to cherry-pick their patients. And if they have patients that aren't compliant or that have more problems, they don't want to see those patients because they're going to make their numbers look bad. And I don't think that's the kind of system that we want to be having.
I didn't mean that they're getting paid based on how health they're trying to that we allow that rating systems that patients are rating their doctors.
Yeah.
That other patients can see with that because they have.
There's no reason why that couldn't happen. And why the information shouldn't be publicly available and transparent. I mean, that's our goal in a human rights-based system, is that people have access to that information.
Okay. If there are any additional questions, I do have one word and then another.
Just a quick question. No, question. Hey, thanks. I know everybody. Okay, great. Well, fellow healthcare advocates, my name is Arthur Holt. My wife is Chrissy. And I just wanted to recognize, I know that there's been a disaster recently in Texas, a disaster going on today, the past week. Earthquakes and other hurricanes and things like that. And what I'm very interested, and I'm not expecting us to answer this question today, if someone does feel like responding, I'd sure like to hear it. Trauma and chronic illness really tends to start in a traumatic catastrophe, in natural disasters, other disasters like being caught in a prison, flooding, that sort of thing. So anyway, I just want to recognize perhaps that I think that healthcare, universal healthcare, is becoming more and more important as the environment becomes more toxic, etc. Climate change, and all that. So anyway, I just wanted to bring that up, perhaps, in everyone's awareness. If it had gotten out of awareness just in the past 2 hours. Thank you.
I will say that my dad, who's a professor at Graduate School of Public Health at Morgan, and also at Hopkins previously, one of the areas that they cover is resiliency. And he travels a lot to Haiti. They're still literally recovering from before. And one of those areas that they've been paying attention to is after disaster relief comes in, and after healthcare professionals and some other physicians come in, then they leave. And what they've determined is that in order to get over and to deal with a lot of these more long-term issues that arise, particularly health stuff, they've begun to look at how some of these populations from the beginning are resilient. And so a lot of that is co-oping, which is one of the models that we're talking about now, is being able is for individual patients to also lend to this conversation for those of us who are on the other side, who are not paid and who do not work for Care First or whoever else, to actually impact that overall system. And that's what we find in a lot of these disasters, is that FEMA and a lot of the others don't immediately go to gatekeepers in the community. They don't go to people in the community and say, hey, how do you all get over stress and trauma as a community? Like, how culturally do you deal with that? I agree with you on that. I don't know. I didn't attempt to answer your question, but I'm agreeing with you because that's incredibly important. And one quote that I like also says, "Please let patients help improve healthcare." So let patients help improve healthcare. Let patients help steer those decisions, strategic and practical, because we should let patients help define what value in medicine is, which to me is ridiculously powerful.
Well, just like 30 seconds, I left out something super crucial. The film, the Milky Way is actually a film. It's a documentary that our foundation made. If you have Amazon Prime, it's free on Amazon Prime. It's about 90 minutes, and it's all about breastfeeding versus in America. And just look up the Milky Way breastfeeding documentary, and you'll go to milkywaytv.com. Thank you. Sorry.
No problem. Also in California, they fund promotoras. Are you all familiar with that? Promotoras, who essentially are caregivers, and they also help with children, and they go inside homes, and they work with health education. So they actually fund that process where they go into communities and into homes and teach about nutrition and guide, almost like a health educator, right, like caseworker, yeah. So it's something to think about as we have these conversations too. Yasmin? Yeah. Yasmin's going to close it out too.
No, I know everybody has left. Thank you for coming, and we have a lot of work to do. but I really wanted to just thank Will, because Will is always there for us, and he has 3 kids, a single dad raising 3 kids, and he's always there for us, and I mean, well spoken, we appreciate him very much, and I don't think you get enough,
So again, power to the people, power to education, power to, again, the indication of the effectiveness of all the work that we do has very little to do with what outside praise we get or how many people are packed into a room, but it all starts with individual action, and most importantly, when you leave this room, it is being able to speak to other people with a little more knowledge, a little more breadth of wisdom as to the information that we got today. And that's what's most important. And that there's children in the room too. Peace.